Morning, everybody. I'm Lori Choma with the Alberta Medical Association. I want to welcome everyone to the Physician Leaders Network webinar on physicians leading quality improvement. Next slide, please. Today, we're pleased to have two of our foremost Alberta experts in the field of healthcare quality improvement presenting for us. June Austin, she's a former registered nurse and quality improvement specialist. She's currently faculty with Alberta AIM, or Alberta Access Improvement Measures Program. She's faculty with the world-renowned healthcare improvement organization, the Institute for Healthcare Improvement. She's also currently a senior consultant with the Alberta Medical Association. With June is Dr. Janet Craig. Dr. Craig is a primary care physician who practices in Edmonton. She's also, along with June, long-standing faculty with Alberta AIM. In addition to her primary care practice and improvement teaching and coaching, she also actively teaches family medicine residents and medical students. So a warm welcome to both June and Dr. Janet Craig. So if you're viewing this webinar as a recording and you haven't downloaded the summary document yet from the Physician Leaders Network website, please take a moment to do that and perhaps grab a coffee before you dive in. And if you're part of our live audience, you'll receive the summary document following this webinar. Next slide, please. So just before we jump into the content of today's presentation, I pass things over. I just wanted to say a few words on the Physician Leaders Network. So it's a new emerging network, and it's for any physician or member of the healthcare team who wants to apply their knowledge, passion, skills in leading the way to an integrated health system. So the Physician Leaders Network has been designed by physicians to provide timely supports, practical resources, and the network is attempting to clear some hurdles and remove barriers toward the promotion of the patient's medical home and health system integration by linking peers in a network so you can learn and share. So there's a number of supports under development in the Physician Leaders Network, and this will be just one of many webinars, and webinars is going to be just one of many supports that's going to be offered to leaders. So without further ado, I'm going to pass the baton over now to June and Dr. Craig to get us rolling on our presentation today, Physicians Leading Quality Improvement.
Thank you so much, Lori, and good morning, everyone. This is June Austin. I'm sitting here with Dr. Janet Craig, and we wanted to welcome you for the next 45 minutes, and we're going to be covering the following learning objectives that you can see on your screen, or if you are perhaps joining us on this session by phone, we really are going to be looking at the three following areas. We're going to learn to identify and begin to describe and consider what it means to have effective physician leadership behaviors that drive improvement in your clinic or your PCN. We're going to talk about the model for improvement and PDSA, and then we'll summarize a stepwise approach to leading improvement work in your team. So please, as Lori said, please watch for upcoming modules to cover additional topics. And remember that this is really an introduction in quality improvement for working in your practice, and there will be other more expansive webinars following. So let's talk a little bit about the foundations of leadership. Here's a quote here that says that really, leadership is about attention. So as a physician leader, your role really here is to identify and define issues that you'd like to improve or you'd like to see as, or you see as being key areas of opportunity. And from there, really your role is to work together with your colleagues in the team. It really is the power of the team to develop that focus and then plan toward that improvement. Attention is really about communicating the importance of quality through everything you say, and most importantly, by supporting the team to find meaning in the goals and to also support them to acquire and utilize the knowledge and skills necessary to achieve that goal, again, as a team. And it's about also having confidence in the abilities of your team, because as is often said, those that do the work must change the work, and this is absolutely true. Leaders of high-performing systems review progress regularly, and they engage in informal conversations very frequently. There's really an importance around their innate curiosity and that real engagement, that they do everything possible to elevate the work of the team. The 5 key leadership behaviors that we're going to go through, that Dr. Craig's going to go through shortly, are around discovering opportunities for improvement, that commitment to learning, working with your team to create that shared vision, supporting testing and implementation, and then finally sustaining and spreading that improvement. And with that, I'm going to hand this over to Janet, and she'll take us through this.
Good morning, everyone. The first thing I want to say is I often get asked, well, you know, we're physicians, we're busy. How can we do this quality improvement work? And the point I want to make is that physicians do not need to do all the work. Rather, they need to lead the work. Use your team, use your improvement facilitators. Be involved, but you don't need to do all the work yourself. So how do we think about what we need to improve? The first thing is you need to look at what opportunities exist in your clinic. Really, we can compare a clinic to a physical body, and like any system, it shows signs and symptoms of dysfunction. So look at what is going well and what is not going well. What could be improved? And just like in our clinics, we use lab values and vital signs to help us diagnose our bodies, and we can use those to diagnose our issues with our system as well. So things like measures, you know, access measures, that sort of thing will help you know how well your system is performing. So, you know, ask yourself, what are the biggest challenges or symptoms of dysfunction you might see in your clinic? Think this through yourself and then discuss it with your team. Gain their input, their thoughts. Do they agree with you? Do they see different things? And then use the measures. EMRs are a very powerful tool. There's a lot of data that we can sow from our EMRs. We also have access to data like Health Quality Council of Alberta panel reports. There's a lot of very helpful data there. Colleagues, what are colleagues doing differently? What new things are they doing? What are they doing better? So, you know, chat with your colleagues at conferences, pick up the phone, send an email, and also look at what's happening provincial-wide and nationwide. There's always databases such as Auditor General reports, the Commonwealth Fund, things like that are available. It's very important that we commit to lifelong learning, but there's so many different forms that learning can take. But be passionate. Take that phone call or email one step further and visit another clinic, see how they do things. Really important that we don't reinvent the wheel or keep doing the same thing over and over again. There's a saying we like to use, steal shamelessly and share generously. There are lots of educational and skill development opportunities provincially. So stay alert and take in as much as you can and ask questions. If you attend a conference, bring that learning back to your home team to share. Sometimes you can take your team to an educational event. Take the time to hear what your team is doing and what other teams are doing and how you can bring all that collective learning into your context. Do any of you have a mission statement? My clinic's mission statement is to provide quality care to our patients in a positive environment. That's what's important to my clinic. But what's important to your clinic? Talk with your staff, and if you don't have a mission statement, it might be worthwhile developing one. It's not difficult to do. Most clinics can do it in 20 to 30 minutes. Inspire them and be inspired by your team. Be a positive force. In some cases, it may take some time to bring them along and get the buy-in, but be patient and consistent in your message. Start with the willing and for sure set an example by going first. Testing and implementation is very important. You need to involve the team and make sure that you have the time, the resources, and that you've done the planning. Don't forget to be your own guinea pig. Go first and work with your team to test. Testing is really important prior to implementation. See if the planned intervention gets the results you're expecting. After you've done some implementation, review the results and look at your measures. Now, finally, if you've experienced some success, it's all too easy to slip back into old ways. So remember that improvement is a continuous process. The most successful teams begin to make it part of their culture. So continue regular meetings, continue discussing what you're doing in terms of improvement. This is really important. Take the opportunity to share some of your successes and present at meetings or at PCN functions, provincial groups, etc. So now that we've talked a little bit about quality improvement and how it can help, we need a framework. June, can you tell us about a framework that would work for us?
Absolutely, Janet, and there really is a proven quality improvement framework to do this work. When we think about change and we think about improvement, it does not just happen because we wish it to be so. We really need to take a deliberate approach to this improvement. Quality improvement, in fact, is a science, and there are some proven methodologies and tools and skills involved. Testing prior to implementation is critical. We're really good in healthcare at basically taking what we think is a good idea and moving right to implementation. That can have a lot of risks with it because if you haven't tested it, we don't really know what the unintended consequences might be, what the cost of failure might be. So by testing, we really limit risk. So let's begin by exploring this foundational methodology, which I think some of you on the call will be quite familiar with, and it's something called the Model for Improvement. There's actually a really large book that you can look at where it really goes through this in detail, but these are really the foundational principles around the Model for Improvement. And some of you might be saying to yourself, yeah, you know, we've done PDSA, Plan, Do, Study, Act, and we know how to do this. The teams that I work with that are the most successful in doing their quality improvement work are the teams that clearly document their PDSAs, clearly set their aims, they're very clear on the 3 key questions. What are we trying to accomplish? What is the goal we're trying to get toward? How do we know that a change is an improvement? So we need to identify the measures of success. What will those measures be? How will we know that what we're trying is working well? And then, with the power of the team, to work together to start to look at what are the ideas, what are the things that we can possibly test to see what will work. Now let's move toward testing. So this is the Plan, Do, Study, Act cycle. When we do this, and this is an iterative process, it's not like you do it once and then you're done. You may go through several cycles of this. And when you're looking at the plan section, what you're really doing here is identifying your objective. What are your questions, your predictions, your hunches? And then you plan to carry out the cycle. Who's going to do this? What are they going to do? When are they going to do it? How long are you going to run the test for? The do is really the in the now. So you actually do it. You carry out the test that you planned on a very small scale, and I'll talk about this in a moment. You document any of the problems that happen and any observations. Some of you may be thinking that this is very, very similar to scientific methodology, and it really, really is. Then we do the analysis or the study section. We look at the data, both qualitative and quantitative. How did it feel? Did it feel better doing this way? And the quantitative, what did the numbers show us? Did it actually result in the, did it bear out the hunch that we came up with in the plan? And then we summarize what was learned, talk about it as a team, and move to act. So what is our next step? Do we need to adapt the plan? Did it work well except for one or two elements that we think that we can tweak really quickly? Was it just a real home run and we say, you know what, let's adopt this? It was a no-brainer. It was really, really simple. Let me give you a quick example. I worked with a clinic once where they had gone to an EMR system, and we were sitting around thinking about what are some of the things that are really bothering the team or seeming to be a problem that we could really solve quickly. The reception staff came up with, well, one of the things we were wondering is, why are we pulling the paper charts and time and date stamping them? The doctors looked around and they said, we didn't even know you were doing that. We don't need to do that anymore. Every time the patient comes in, it actually gets time and date stamped on the EMR. They didn't even move to PDSA with that, although they did try for one day to see how long and how much time it would save to actually quit pulling the paper charts and date and time stamping them. That was a no-brainer. That was a quick to adopt. Sometimes when we do a PDSA, it is an abysmal failure, and that is actually a wonderful thing. There's a team that I work with in the U.S. that actually has adopted this as their phrase: test early, fail often, learn quickly. So sometimes we need to abandon, and then we say to ourselves, what will the next cycle be? So the cycles build upon each other. As I said, we start with our hunches, theories, and ideas. We test on a very small scale. So think about oneness. Can we test it with one patient, one time, one day, one doctor, 1 week? It always makes me a little nervous when I hear clinics saying, we're going to test something and we're going to test it over the next month or the next 2 months. That's a little bit long. Can we rapidly cycle through this? And can we start with a really tight control group and move forward? Then do some follow-up testing. Then we widen the scale of the test and the test of change. So if it worked with one receptionist, we might try it with the second receptionist. If it worked with one physician, we try it with the second physician. If it worked with one population group of patients, let's try to the next population group. Once we feel confident that the test has resulted in improvement and it's ready for implementation, everyone agrees, we implement the change by really documenting it and adopting it as actual practice now in our clinic. So why do we test? Well, it's really difficult sometimes to engage with people and for people to actually believe that a new way could be a good way of doing something. So it really increases the degree of belief. If you're having challenges with getting people to buy in your clinic, if you've tested something and it's been successful, often this will pique their curiosity, or that it will allow you to open up the conversation and say, you know, I actually have some data here, although it was a small test of change, that this might actually really work. It allows you to start to document your expectations, and I can't stress this enough. Keep careful track of your quality improvement work, because if something failed, then you don't want to go back to that 6 months later and try it again. Go back to your documentation and say, what happened when we tested that? Has the context changed now? Should we try testing it again? And of course, as I said, it does minimize resistance. People are willing to take a small risk, a small chance, that they are much more fearful, with good reason, for going to wide-scale implementation. We have the opportunity to learn and adapt. We can look at the test, we can tweak it, we can abandon it, all of those things. And we really have the ability to evaluate the costs and the side effects, or maybe some of the unintended consequences prior to full-scale implementation. So in short, you really need to form that team. The best teams that I see coming through to do this kind of quality improvement work at the clinic setting represent all facets of the team. So in a small clinic, it might be every one of you. I've worked with single physician clinics where it's the entire clinic. Or if you're working in a larger clinic with up to maybe 15 physicians or more, you have physician representation, you may have an MOA representation, front of office or reception, someone in administration, and other groups that you may have within your practice. You need to know where you're going. You really need to set a measurable aim. Again, do that with the team. It is amazing how many members of your team actually will come up with the most fantastic ideas, will actually be the levers of success. You need to know what you're currently doing in order to know where you're going and what you need to do to get there. So you can map your processes, so you can actually do step by step to see what's currently happening. As Janet said, look at your data. What is your current state? This is really about current state analysis. From there, start to identify your measures that will tell you whether a change was an improvement. Identify some potentially better practices. Think about some of the things that have been niggling at you that you'd really like to do. Are there things that you're missing, such as screening opportunities? How can you develop processes so that it's not just a haphazard way of doing this, that you actually have a clear process? Use the model for improvement, use PDSA to test your changes. As you grow confidence in those tests of change, begin to adopt those successful tests by clearly documenting. This can be a great place to create procedures and for training, and then move to sustaining and spreading this. So if you create a procedure, something like that, you can't just put it on the shelf and never look at it again. Please also, as part of that, create a process to regularly review processes and to see have things changed and or have processes degraded over time, and do we need to revisit them? So does it really work? And I'll pass it over to Janet to tell us about some maybe examples of where it has really worked.
I'm going to tell you a story that I like to call the Happy Hooter story. So a clinic in Alberta, when they were involved with AIM, they looked at their screening mammogram rates for women between the ages of 50 and 75. And their screening rate was pretty low. It was well below 60%. So what they wanted to do, their goal was to improve their screening rate. And they did a baseline measure, and they knew what their baseline measure was percentage-wise. So PDSA cycle number 1, the physicians all agreed to talk to their female patients when they came in for any reason, check the chart and see if they had a mammogram in the last 2 years, and if they didn't, give the patient a requisition and ask the patient to do a mammogram. So after a few months, they measured their screening rate, and guess what? Their percentage really hadn't improved very much. The physicians sometimes forgot, they were too busy, it wasn't successful. So next PDSA cycle, they decided that the nurses would ask the patients to go for mammograms and give the patients requisitions. So that went on for a few months. They remeasured their screening rate, and again, it had gone up a little bit, but not significantly. They talked about why they didn't think the nurses had been successful, and again, the nurses said they don't have enough time, the patients weren't receptive. Finally, one of the receptionists said, you know, I think I could do this at the end of the day when the phones are quieter. I have a little bit of time and I could phone some patients. So they set up a plan where the receptionist had a list that was mined from the EMR of all patients that were overdue for their mammogram. The receptionist took turns calling the patients and used a script that was developed by the physician and by the nurses. And she was very receptive to helping the patients get a mammogram however they wanted. So she would mail the requisition, they could pick it up, she could phone and book the appointment if that's what they wanted. And finally, when they remeasured screening rates after several months, guess what? They had success. Their screening rate was around 90%, which was their goal. So this is how this can work. It's not a big scientific project. It doesn't involve a lot of time. It involves listening to your team members and seeing how they can help, how you can work together. It involves choosing something that's important to you. So this clinic, obviously it was important to them that women got their screening mammograms. So this is how it can work for you. So where do we go from here? Well, think about what challenges are happening in your clinic. Talk to your team. Consider what you could do differently and how you would test it, and use the resources available to you. You know, after the Happy Hooter story, can you think of something that you could do at your clinic and expand on this example and use in your own setting? So there is help for doing quality improvement. There are lots of PCN resources. There are lots of tools out there. And as a physician leader, you don't need to understand all these tools, but just know that they're out there and help is available. Most primary care networks have improvement facilitators that can help greatly with any improvement work you want to do.
I'm just going to jump in here and go back to that story of screening mammograms and bring it back to the model of improvement. So if we think about the model for improvement and we think about this clinic's example, and we'll think about the 3 questions. So as they asked, what are we trying to accomplish, it was quite simple. They wanted to improve the rate of mammogram screening from baseline, and they were sitting somewhere around 60%, and they knew that they needed to increase that. Then they said, well, how will we know that a change is an improvement? Because they knew the baseline rate of mammogram screening for eligible women, they knew that that was going to be their measure. And they actually tracked that data through the several cycles that they went through. So from the physicians trying it, didn't show too much improvement. And then they moved to the nurses trying it, a little bit better, but not what they were expecting. And finally, much to their surprise, they actually got to the 3rd cycle where the receptionist said, hey, can I give this a whirl? And they gave it to her, and that's when they saw real improvement. So you can see through this that they actually went through 3 cycles of this PDSA, and it went very well for them.
So there are lots more resources available should you need them. There's Towards Optimized Practice has a quality improvement guide. There will be some more webinars. They're being developed by the Physician Leaders Network. And there also is a summary document that summarizes what we've been discussing in this webinar today. These are the partners. So June, before we move on to questions, is there anything else that you wanted to add?
Thanks, Janet. Well, I couldn't underscore more the power of the team. And really, you know, this concern often that I hear that physicians are really concerned about the amount of time this is going to take. And absolutely, I'm not going to lie, it does take some time. And the teams that really do this well are the teams where, as a physician, you really lead the team in terms of your attitude, in terms of your inclusion of the team, in terms of supporting their ideas and really creating that environment where everyone feels safe and valued in terms of bringing their ideas forth. Once people are feeling that sense of teamness, if you will, then it's quite very easy for them to say, hey, I'm willing to take that on. And then as a physician, it's really about monitoring the progress, showing interest in the hallway, stopping with the receptionist and saying, hey, how's that test going? Let me know how that's going. And then about spreading it through your clinic. Some of the clinics I work with will actually create an improvement board, and they'll post it in a central area. That helps the other members of the team, particularly if you're a large team, to really start to engage in it and look at the board and say, wow, what are you guys on the improvement team testing? The other importance about the improvement team is that if you are, in fact, a large clinic and you have one MOA or one receptionist representing on your improvement team, then it really is part of their role, and we need to really help them to understand that role, is to take that information and the work that's happening in the improvement team back to their team and to spread the word, if you will. So it really is about your attitude, about your desire to move forward more than anything as a physician.
Another thing I want to add is make sure you have the right members on your team. I can think of some clinics that have done some quality improvement work, and there's just a physician and maybe the office manager on the team, and they decide to do a quality improvement project involving the MOAs or the reception, but they don't have any input from the receptionist or the MOA before they make their plan. That just doesn't work very well. So make sure you have the right people on your team, representatives from all the different work categories.
And finally, I just want to end with, and I'm just going to actually, and sorry, I know that we're on webinar and you can see the screen, but I actually want to go back to a slide that actually talks about QI in short. So really, in summary, form a team. Be the leader of the team, but let the team really elevate themselves. Set a measurable aim, map or identify your current state, really diagnose what's going on in your clinic. Identify what the measures are going to be that you look at in terms of moving forward with success. What will tell you whether this is going to be successful or not? Identify some potentially better practices. What are some things that you could test? What are some things that you would like to adopt in your clinic? Whether it comes from evidence-based like a CPG, or maybe some tips and tricks that you got from Alberta AIM, or whatever it is. Test those changes using the model for improvement. Once you are confident in those tests of change, adopt the successful tests, and then move to sustaining and spreading those tests.
Does anyone want to use the chat function and ask us some questions? Or you could ask them over the telephone, whatever your preference is.
Or any comments that you may have about improvement work that you've done yourself. What have been some of the challenges for you? How did you overcome those challenges? What's it been like for you out in the field?
Hello.
Hello.
Hi, it's Jane Valentine. I just had a question, and I don't see it in your sort of process, but I would throw it out because it was a learning that we had. And sometimes when you run your data, you have to ensure that your data passes the sniff test before you act on it.
You bet. You bet.
Sometimes it's because I think we sometimes forget that screening is about the normal population. So we get lulled into this sense that if we look at all of our women in the right age group who haven't had a mammogram done in 3 years based on the guidelines, the answer is our patients with prior breast cancer or high risk or family history that really should be being done once a year, we're not addressing. So we have to be careful that screening is not the same thing as care. So we need to be a little bit cautious that we need to put it into context and recognize there are patients that are being captured in this screening run that probably we aren't doing what we should be for them. We need to find a way to better address those patients who need more than screening, if that makes sense.
Yeah, that's a good point.
Yeah,
Same with PAP tests.
Yeah, for sure, Jane. And you know, sort of more globally thinking about this, it's about doing that deeper dive into the data and really thinking through it critically. And I really like that you brought that up. It's fantastic. Even when you're looking at data such as process data, so how often are we doing something? I love that you use the terminology passing the sniff test. It's something that we use often as AIM faculty. When we look at the data, we need to know whether the data has somehow been, in one way or another, is it actually accurate, right? Like, you know, so if we look at it and we go, that can't possibly be right, like, you know, then we need to look further because sometimes we're not capturing the data properly. And we may have to take a step back and look to see actually, you know, is the diagnosis that we're making of our clinic actually accurate?
I would agree. I also think that, so Experience PCN has people who aren't the clinicians, who aren't in the office, who don't understand the process, and they run numbers out of the computer and hand you numbers. And so that conversation not happening risks us making decisions based on information that isn't grounded in the right place. So the conversation piece, I think when you form your team and set an aim and then you look at what's happening, I think you have to go back and look at that and say, okay, is this what we want? Is it just screening we care about?
Right.
So that it's on the front burner, because it's easy to say, yeah, the doctors can all exempt them for 1 year so that it shows up again as a rule so that it reminds you, but you have to be cautious that it's much more about, I don't know how to put it. I think the screening guidelines, okay, so we did one with FIT, and the FIT guidelines say FIT every 2 years, SIG 5 years, and, sigmoidoscopy 5 years, and colonoscopy 10 years. So they interpreted that to mean that if you had a sigmoidoscopy in your chart, you didn't need anything for 5 years. And if you had a colonoscopy in your chart, you didn't need anything for 10, which is interesting because that's not what the report says. You have to drill into the report and specifically take that recommendation and put it into a rule. But when we dredge EMR, we look for yes or no, or this tick box or that off. So we need to be careful when we come at it from a, hey, we can pull these numbers, totally out of context. I think we start a conversation that puts us almost at odds, as opposed to, hey, we're on the same team, we're working together to try to figure this out. I've taken a first shot at this, but I recognize it's not in clinical context. Help me understand, and we may need to do this, because it's like it's getting measured by people who look at numbers only, and we're saying, but those are patients. That's an individual, and our goal is to provide care patient-centric.
You bet.
So we just have to be careful as we blend those two. So.
Right. I mean, the bottom line is we want to provide the best care to our patients, whatever is appropriate for them.
Yeah, you're very right. And bringing it back to a principle in terms of looking at data, we really need to understand, as you say, that where that data is coming from and how it's being formulated as it spews forth and we actually see it on the sheet. So let me give you an example. Many years ago, I worked via a project through the Alberta Medical Association. I was doing some chart reviews at a clinic, and one of the physicians said to me, just for fun, June, can you just go in there and see if we can pull a list of all of the PAP tests that have been done? And when I went in there, what I discovered, and I stopped counting at 7, that PAP results were put in there at least 7 different ways. So if I was to pull a query and I was to actually want to understand how many PAP tests were done, I really couldn't reliably look at that data. So I went back to the physician and explained to him what I had found, and where they needed to take a half a step back was correcting that data so that now we could build the query and get the actual current state data so that we actually knew where we were starting from so we could move forth with a possible PDSA, because we wanted to know what the baseline was. So very important for us to know how that data is being formulated in the background, and then what we see, are we interpreting it? We are understanding what we're wanting. Is it the same thing that is actually, being collected, being input, and then being translated through our EMR or wherever we're getting it from?
May I add one other learning?
Sure.
We looked at diabetes, and the ICD-9 code for type 1 is 250.01. The ICD code for type 2 is 250.02. But in Wolf, it doesn't transfer to the billing program. The billing program doesn't have 2 decimal places. So we had to make them all 250 in order for that to go into your billing, for it to be recognized. And in order to decipher the difference between type 1s and type 2s, you needed to put in the second code with the proper distinction. But then when you ran a query at who you could do a complex care plan on, 2 from A showed up our type 1s who had 250 plus 250.01.
Mm-hmm. Yeah,
but it's the confines of the environment in which we find ourselves.
Yeah, absolutely. And that's really where you need that team, because oftentimes they're the ones that will go, well, actually, I think this is what's going on in the background. And so having that team is really important. And I think we have a question in the chat as well that has come through. Just going to take a quick look there.
So hi. June, do we have you, Tina?
Oh yes.
Yay! Okay.
Yes, finally you do. Sorry, I was having some real problems there. Yeah, I was just I was going to respond to Jane really, because I absolutely get what she's where she's coming from. And just thought I'd share a little bit of my experience. I work as one of the medical directors on the PLP team at the University of Calgary, and as such have been going to groups of physicians and helping them understand some of their data from various sources like HQCA, and then try and implement some QI projects as a result of that. So that piece about understanding the limitations of data is extremely important. And obviously coming back to that, I mean, really, essentially what Jane was saying there is the inputting of data or the coding is so important to get the right data out again. I think knowing your panels is hugely important. And I think creating the searches in a meaningful way within your own EMR so that you can compare them against your external reports, or even involve a team like PLP who can do a more focused search, giving you more meaningful data, can really help you in the process. And just a quick example of one that we've done in our clinic was a PDSA cycle around the periodic complete examination, and trying to look at our screening rates, but also make sure that people are, again, speaking to what Jane was saying, making sure that they have the right reminder, because if you default to reminders, it will not capture everybody. And actually, what we had was one of the nurses and the MOAs going through patients who were already booked for physicals, and contacting them about 2 or 3 months ahead, looking through at their screenings and encouraging them to go and get these tests done so that there was an opportunity to talk about it by the time they came for their physical. And that's been rolled out across the clinic, and actually it's been wholly successful with both patients who really enjoy not having to come 3 times to do all these things, and the physicians. And I've just got my HQCA report from this year, and my screening rates have actually gone up dramatically in the last year since doing that particular PDSA.
Wonderful. That's great. Any other comments or questions out there in terms of, you know, if you're new to this work, it can perhaps be a little bit, you know, feel a little bit daunting. Is there anybody out there that has any comments or questions about, you know, how do you embark on this if you haven't done this already? Or any other comments or concerns out there?
Hi, it's Tina again. Sorry, I'm not going to monopolize, but I'll just let you know, our clinic is 15 physicians. It is PCN managed, so it's not as if there is a physician owner in this clinic. And the way that we've made this successful is to identify a QI team in the clinic, which includes an MOA, an LPN, a receptionist, and our manager, it's as well as a representation of physicians across the clinic. But setting that team, setting the rules for the team so that everybody's input is equally important. And I think that was probably the most impactful piece that we learned from going through AIM that made us successful going forward.
Thanks so much, Tina. That's really, you know, I think both of us are thinking, wow, that's so great to hear.
Yeah, and I think you've hit the nail on the head that you need to have equal representation, and all members need to feel that their voice is heard and is important. And it speaks again to making sure that you have all the right members on the team, and you've formed a team that represents all the different work categories in your clinic. So that's terrific. Thanks for sharing.
No problem.
It's Jane. We also have a large clinic, around 15 primary care docs, and what we found is that turning on any number of rules in WOLF at one time overwhelmed most people. So even the tools that are available, easing them in, and then when some people have some success with them, to then be able to take that, as you call it, share and spread, and say, okay, can we move this to a clinic-wide? Ours hasn't been as organized as the QI committee, but rather a couple of physicians who've had some interest, and we've taken slightly different directions. We also did a diabetes program with facilitated discussion that was facilitated externally, and that really helped, and then we could take the learnings that we had from that and expand it. But in that time, our clinic grew, so then we had people at varying stages. So the idea that we don't make everybody get up to the same place all at once has been helpful. You
bet. That incremental step, and it's about testing those changes. So perhaps, Jane, you were the first one to maybe turn on some of those rules. And maybe you didn't turn them all on at once, because that would be kind of overwhelming. And so then as you started to get used to using them, then, you know, maybe one of the other doctors tried, and we began to spread that way, rather than one morning we all show up and the rules are all turned on, and before you know it, you have sort of a, you know, you have a revolt on your hands because people are really upset that, you know, how dare you just have gone ahead and done that. And I think that we've all experienced something like that. So that takes us back to, again, you are informally, in a sense, doing that that model for improvement sort of structure where you're starting small, then you're spreading, and then you're moving forward, you're adding more people, and slowly helping people to get used to this until it becomes the way that you do it. Really glad to hear that. We see that often informally in teams, and as I say, the teams that I see that are the most successful with this is when you clearly plan that out and you clearly have that documented, well documented. But that's a very really real-life good sharing from both of you about having that team and then that incremental spread of change.
I've got a question just to the open forum. Has anybody got any hints and tips about those doctors skeptical about doing things, or the ones who really, I have some challenges with some of the very established physicians who've done things in a particular way forever, and encouraging change is really difficult. So, you know, even with the best in the world, trying to engage can be very difficult. So I'm always interested to find out how people navigate those individuals. And it might not just be doctors, it might actually be staff as well.
Mm-hmm. I think one thing I can suggest is you need to find out what's important to that individual. So,
yes.
For instance, if there's a physician and their goal is to get out on time at the end of the day, if you can show them something in the EMR that will save time, you'll probably get buy-in.
Yeah.
So sometimes it's to find the currency, to find what's important to that individual and how this change might make things easier for them.
Yeah, I agree. And that is something I've tried to, you know, find that motivation, I guess, as to what. And I think that's especially important with the staff, because if the staff understand the principles behind why you're asking them to do something a little bit differently, they often do grasp it very enthusiastically. Whereas if you're just giving them a task as another task for their day, you know, that will just fall by the wayside. But I think, again, it's back to what Jane was saying. You bring in the patient's story and saying, well, you know what, we can actually do some outreach work here and try and prevent a breast cancer being missed, or prevent somebody from missing the screen that they should have had because they're not on the schedule that we think they should be.
Yeah, very much so. And when you're thinking about staff and even your physician colleagues, it's really down to the piece for me in the years of doing this where everyone wants to feel valued. Everyone actually does have good ideas, and everyone really wants to be part of that. And so if we are very inclusive that way, then, you know, our chances of success are much greater. And also, too, the recognition that resistance to change is actually a very, very normal reaction. And it's about really about, you know, working with that individual, finding their currency, having that discussion. So we're going to have to wrap up now, and we want to thank you very much for your attention and for your participation today. There will be other webinars in this series, and there will be other webinars in this series coming forward, and so we invite you to watch out for those as well. And we'll wrap up there, and thank you very much. There are more resources available as we're showing here on the screen, so have a look at the Top Quality Improvement Guide. Turn to your PCN. Many of the PCNs now are really bolstering their improvement capacity. Alberta AIM can certainly help with any access issues, and we've got some more webinars coming. And overall, I mean, I really think that we're starting to see this movement moving forward. You will be, if you're a participant here today, be getting sent, I believe, this summary document for this webinar today. And Lori or anybody else on the call, any final thoughts, or are we good to wrap up?
No, I think we're great to wrap up. I just want to thank you, June, and Dr. Craig for your excellent presentation today, and all of our guest participants for taking the time to join us. And we look forward to seeing you in the field. Please be in touch with us if you have any questions about today or the recording. We look forward to chatting again. Thanks, everyone.